Hello, my name is Ingrid Wolfe. I'm the Director of King's Health Partners Women's and Children's Health. I'm also a consultant in paediatric population health at Evelina London Children's Hospital, and I'm a reader in paediatrics and child health at King's College London. I'm very sorry that I can't be with you today, but I'm grateful for the technology and the team that supports all of that to allow me to be part of your day indirectly. So that's the next best thing. So I'm going to talk about the vital five, or the vital metrics, because we don't quite know how many they're going to be for babies, children, and young people. So you'll have already heard a lot about the vital five, and you'll know it's a program of work that we've been dedicated to at King's Health Partners for a long time. It's all about measuring and improving important risk factors that contribute to poor health, to reduced lifespan, and that are important contributors to inequalities. So the Vital Five is great in its ambition, but there are a few things that give me some pause for thought. The first, as a child public health doctor, is to recognize that what we're talking about are intermediate risk factors. And so we're not addressing, partly because we're not able to, we're not addressing the structural risk factors that underpin pretty much everything we're talking about, and that's poverty and economic and social inequality. So it's important to recognize that. All that said, we have to address ourselves to what we can do and achieve, and there's a lot that we can do. So let's focus on that. Now, the next thing that jumps out at me is that all of the Vital Five that we've been talking about is largely focused on the adult and older populations, not so relevant for babies, children, and young people, or not adapted to be relevant for babies, children, and young people. So what are we going to do about that? Okay, so if you think about the early years of the life course, things that matter in terms of health and well-being and outcomes for babies, children, and young people are quite different at each of those stages. And of course, those stages seamlessly join up, and some of the risk factors will go across all, but not everything. So we really need a more nuanced approach to think about each of those stages, largely three groups. So many of the important risks and assets, we mustn't forget to think about assets and health problems, might not already be routinely measured in the way that many of the Vital Five that you've heard about already are. So that's another thing we need to consider in the early years. What do we already measure that we can take advantage of, and what will we need to put into place to start measuring? Then it's really important that each of whatever we decide is worth measuring and we can do something about it, that we link those measures to interventions to improve health. It's really important that what we measure, we then try and help. So implementing this program for the early years should help improve health and the quality of care, but it's going to be something that requires coordinated efforts across sectors. It's not just healthcare, it's public health, it's schools, it's local authorities, it's environment, lots of things. So this is going to require an intersectoral approach. So there will be challenges, no question, but the potential gain could be substantial for babies, children, and young people who deserve that attention in their own right, but also across the whole life course, because we know that improving things early brings benefits all the way across life. So our proposal for from King's Health Partners Women and Children's Health is a piece of work that helps us get started. So what do we need to do first? We need to define and agree, what are we going to measure for babies, for children of sort of middle and school years, and for adolescents and young people. These need to be measurable, they need to be valid, that is, that they measure what you think they're measuring, and then there needs to be some evidence for what you can do about it that is realistic and implementable. What we would then like to do is develop a way of displaying that data in a dashboard or something similar to be able to support us all in measuring and monitoring what's happening. Is it getting better? Is it getting worse? What are the social patterns? What are the differences between social and ethnic groups, for example, for each of those measures, so we really can understand whether things are getting better, getting worse, and whether we are having an impact with what we're doing. So later on, we'll need a program of work to put into place those interventions. So The wider context of all of this is important because it really matters to what we're here for today, what we're all committed to. Someone told me a long time ago a really helpful phrase that has rung in my mind ever since. What gets measured gets done. Or perhaps more constructively, you can't improve what you don't measure or what you don't understand. And that's really largely what we're talking about today. And the wider plan that we're all committed to, which is embedding evidence into practice and improving the way that we evaluate and learn from what we're doing as an academic health science center, now system. And most importantly, that we do those things in order to improve the health of our population and to reduce the dreadful inequalities that really diminish and shame us all. So thank you for your attention. I hope the rest of the day is inspiring and energizing, and that you come away from today's meeting motivated to get working, to do all of the things that we've now spoken about. Thank you.